So, good evening. First of all, I would like to extend my gratitude to PPS Northern Luzon for making me a part of this lecture series. The topic that was given to me are the blastomas. My topic outline are the following. I will describe each tumor. I will also mention the different clinical manifestations, the diagnostics, epidemiology, management, and prognosis. So let's start with describing the blastomas. Blastomas are malignancies in precursor cells, which are the blast, and each kind is given its own name depending on the site of the body. It is more common in children, and these are the different blastomas, part of which I will uh, I'm going to discuss for this evening. Let's start with retinoblastoma. Retinoblastoma is the most common intraocular malignancy in children. It is a malignant tumor that develops from embryonic neural retina. It can originate from one or more foci in one or both eyes. In developing countries, it is diagnosed only after an enlarged eye or in the presence of gross orbital extension. And the most common presenting sign is leukocoria in one or both eyes. White pupillary reflex is seen instead of the normal red reflex. Large tumors cause retinal detachment leading to retrolental mass visible through the pupil, and small tumors are centered in the macula. This gives the leukocoria or the white pupillary reflex. Strabismus is the second most common presenting sign. There is a loss of central vision from a tumor in the macula, resulting to disruption of fusional ability and cause the affected eye to drift. Because of this, the patient will also have decreased visual acuity. Hemocoria or the dark red reflex and Nigrocoria or the black reflex can also be seen in patients with retinoblastoma. This is secondary to vitreous hemorrhage from bleeding of the retinoblastoma vessels. Heterochromia or the different color for each iris can present as initial signs secondary to iris neovascularization. Robiosis iridis can also be a presenting sign. This is secondary to neovascularization of the surface of the iris, secondary to extensive necrosis of the tumor and liberation of angiogenic factors. Pseudohypophyton or the anterior chamber proceeding from endophytic tumors can also be a presentation of retinoblastoma. Spontaneous hyphema is the presence of blood in the anterior chamber from the spontaneous bleeding from robiosis iridis. Close-angle glaucoma is secondary to mechanical obstruction of the anterior chamber angle by the iris and lens that has been pushed forward by a large intravitreal tumor. Most children with this undergo enucleation. For the epidemiology, almost entirely, retinoblastoma is restricted to early childhood. It predominantly affects young children and often, but is not usually recognized at birth. 11 new cases per million population of less than 5 years old, and 80% are diagnosed before 3 to 4-year-old with an average of 2-year-old. The occurrence beyond 6-year-old is rare. We also have bilateral retinoblastoma. This is diagnosed earlier than unilateral, and it manifests in one eye many months before evidence on the other eye. Sporadic bilateral retinoblastoma is associated with advanced paternal age, but not in advanced maternal age. For the genetic counseling, majority appear sporadically. 40% have inherited form transmitted as autosomal dominant trait. 45%, there is a 45% chance that any child of the patient will inherit the disease. And one of the siblings could also develop retinoblastoma even if neither of the parents were affected. Genetic testing of siblings and offsprings for germline mutation in the RB1 gene is recommended. However, if it is not possible, tumor surveillance can be done. All children with a family history of retinoblastoma should be screened shortly after birth by ophthalmologists. The current recommendation is that examination at birth and after every 4 months until the child attains 4-year-old. Unilateral disease requires genetic screening at the time of inoculation. Early detection decreases metastatic presentations and increasing the chance to salvage the affected eye. Suggestion is that to include dilation of the pupil prior to examination at the first well-child visit. This will give an additional benefit of screening for the treatment of congenital and infantile cataract. For the diagnosis, retinoblastoma is one of the only human tumors radically treated without biopsy confirmation. Diagnosis is based on the gross appearance of a creamy pink to snow white mass projecting into the vitreous, as seen on the side of this slide. Diagnosis is done by ophthalmoscopic, ultrasonographic appearance, and pathologic confirmation is unnecessary. FNAB allowed patients benefit from pre-treatment biopsy. However, it is recommended only in cases where diagnosis is ambiguous and when adequate steps are needed to prevent extraocular seeding. The accuracy is 95% and the accuracy of cytologic interpretation is 100%. Ultrasound, MRI, and CT scans are frequently used to confirm the diagnosis and to detect ectopic disease in the pineal gland. MRI of the orbit is more useful to detect soft tissue tumor, extension into the optic nerve and orbital coats. CT scan is better for provide confirmation of retinoblastoma. Lumbar puncture to obtain CSF cytology and MRI or CT scan of the brain to rule out brain metastasis can also be performed. BMA or bone scan are not warranted unless there is a systemic involvement. The goals of treatment of retinoblastoma is that, first and foremost, it is to save the child's life. Second is to preserve as much vision as possible. And third is to avoid external beam radiotherapy in patients with heritable retinoblastoma. For the prognosis, this depends on the site of recurrence or progression of retinoblastoma. If it is confined in one eye and is small, the prognosis for sight and survival may be excellent with local ophthalmic therapy only. However, if it is extensive, the prognosis for sight is poor, but the survival is excellent. But if it is extraocular, the prognosis is guarded. So young children learn through their eyes. Healthy vision is critical for every child's development, school success, and well-being. And the best way to prevent vision loss is through early detection. And this lies in the hands of the clinicians. Our next topic would be on neuroblastoma and nephroblastoma. So what is neuroblastoma? Neuroblastoma starts in immature nerve cells called neuroblast that the fetus creates during its development process. It originates from the primordial neural cells that normally give rise to adrenal medulla and the sympathetic ganglia. The site at which it arises correlate with tissues of the sympathetic nervous system. On extracranial solid tumor. It is the most common and deadly solid tumor in children. 8 to 10% of all childhood carcinoma is retinoblastoma. This is the most common cancer diagnosed during infancy. Therefore, it is a disease of early infancy and children. Highest number are diagnosed in the first month of life, and the median age at diagnosis is 19 months. It is rare, but it can also occur in adolescent and adult. The primary site is similar to children. The course is more indolent but frequently fatal. But even localized tumors can be recurrent and ultimately fatal over a long period of time. For the epidemiology of neuroblastoma, the etiology is unknown and there is no data supporting the role of environmental exposure. There is a positive association with congenital anomalies like urogenital and cardiac anomalies. The outcome in infant is better than older children because it may regress spontaneously or may mature into benign ganglioneuroma. For the clinical presentation, it arises from any site along the sympathetic nervous system chain. Most primary tumor occur within the abdomen. The frequency of adrenal tumors is slightly higher in children compared with infants. Infants have more thoracic and cervical primary tumors. A primary tumor cannot be found in some children, and majority are diagnosed by age of 5 and rare after the age of 10 years. This slide shows the distribution of neuroblastoma. They can be seen on the neck, chest, or it can also arise from the abdomen and the pelvis. For the clinical presentation, they metastasize by lymphatic and hematogenous route. Hematogenous spread occurs most frequently to the bone marrow, cortical bone, liver, and skin. It rarely may spread to lungs or CNS at diagnosis, and this is more common as end-stage or recurrent disease. Signs and symptoms reflect local, regional, and metastatic disease. Neuroblastoma presents as an abdominal mass which is fixed, hard, with borders difficult to define due to retroperitoneal origin. The child may also manifest with fullness and discomfort. Bladder or bowel symptom can also be present due to compression. Massive involvement of the liver with metastatic disease may result to respiratory compromise. Metastatic abdominal tumors may result to compression of venous and lymphatic drainage from lower extremities, causing scrotal and lower extremity edema. Rarely, renin-mediated hypertension can also be present. Hypertension, tachycardia, flushing, and sweating are uncommon symptoms. High thoracic or cervical tumors can be associated with Horner syndrome or oculosympathetic paresis from an interruption of the sympathetic nerve supply of the eye. Exophthalmos plus the triad of miosis, ptosis, and anhidrosis is the manifestation of the Horner syndrome. These are the components of the Horner syndrome. There is miosis or a constricted pupil, anhidrosis or there is a loss of hemifacial sweat of the upper eyelid. Large thoracic tumor is associated with mechanical obstruction and resultant superior vena cava syndrome. They manifest as swelling, plethora, and cyanosis of the face, neck, and the upper extremities, suffusion of the conjunctiva, and engorgement of neck collateral veins. Altered mental status is also present. Paraspinal tumors in the thoracic, abdominal, or pelvic region may cause compression of the nerve roots and the spinal cord. Subacute or acute paraplegia, bladder can be secondary from these tumors, and these are medical emergencies. Ptosis and periorbital ecchymosis is also presently seen in patients with neuroblastoma, and this is from tumor infiltration of periorbital tissues. Bone pain leading to limping or irritability in a child is secondary to the bone and bone marrow involvement. So if you have a patient who is limping, one of the differential should be possible neuroblastoma. Bone marrow replacement will manifest as anemia, bleeding, or infection. And failure to thrive and fever is secondary to the extensive bone metastasis. The skin involvement of neuroblastoma is manifested as non-tender bluish subcutaneous nodule. Paraneoplastic syndrome is secondary to anti-neural antibodies directed against the tumor that cross-react with neural cells in the cerebellum or elsewhere. And it manifests as opsoclonus, myoclonus, and ataxia. Tumor secretion of vasoactive intestinal peptide cause intractable watery diarrhea, hypokalemia, dehydration, and failure to thrive. So if you have a patient with this manifestation, neuroblastoma can also be one of the differentials. It is important to evaluate and estimate the location and size of the mass. Hepatomegaly is also an important finding in neuroblastoma. We must also examine all lymph node structures. An enlarged left supraclavicular node may be seen in high-risk neuroblastoma with intra-abdominal disease and extensive dissemination. Neurologic examination, especially in young patients with paraspinal masses, is important to ensure that evolving paralysis is not missed. For the genetic predisposition of neuroblastoma, it has an autosomal dominant pattern of inheritance, and family history is present in 1 to 2% of newly diagnosed cases with incidence ratio of 9.7% for siblings of index case. The goal of diagnostic testing is to definitely establish diagnosis and precisely define the extent of the disease. For the establishment of the diagnosis, we have two diagnostic criteria. First, if there is equivocal pathologic diagnosis from tissue with or without immunohistology, electron microscopy, or increased catecholamine. But if pathologic diagnosis is not possible, we can do bone marrow aspiration or bone marrow biopsy, and it should contain equivocal tumor cells, plus there should be an increased urine or serum catecholamine. CT scan is preferred for the evaluation of primary tumor in the abdomen, pelvis, or posterior mediastinum. MRI is superior for paraspinal lesions, and either modality to evaluate primary tumors can be used for primary tumors arising from the neck. CT scan of the chest, abdomen, and pelvis, CT or MRI of the head, neck, and or spine are performed on the basis of physical examination. Evaluation of the bone marrow and bone skeleton is also important. This is done through BMA or refined biopsy, bone scan, and plain radiographs. Neuroblastoma express essential enzymes involved in the catecholamine synthesis. Homovanillic acid and vanillyl mandelic acid are the metabolites that show highest sensitivity and specificity for tumor detection. Therefore, urine VMA determination should be a part of every diagnostic workup. Because neuroblastoma frequently produce increased levels of catecholamines detectable in the urine. For the treatment modalities of neuroblastoma, first surgery, then followed by chemotherapy and radiotherapy. For the prognosis, stage 1 and 2 tumors with more than 50% resection in patients with favorable histology have an event-free survival and overall survival of 90%. For stage 4 disease, the EFS is 86% and overall survival is 92%. However, for tumors with MCY and gene amplification, these are advanced stage disease and they are high risk of treatment failure. Loss of chromosome 1p, 1q, or gain of 17q have an increased rate of recurrence and decreased survival. The presence of diploid DNA content makes the tumor less favorable, and the presence of hyperdiploid DNA content makes the tumor more favorable. So after neuroblastoma, let's go to nephroblastoma. Both neuroblastoma and nephroblastoma are intra-abdominal tumors, and sometimes it is difficult to to differentiate one from the other. So this slide will show the differentiation between the Wilms tumor and the neuroblastoma. Wilms tumor and neuroblastoma are both abdominal masses. However, Wilms tumor is an intrarenal tumor, but neuroblastoma is extrarenal. On physical examination, Wilms tumor is mobile. The mass is mobile, mainly, and it is mainly confined to the flank. But for neuroblastoma, it is non-mobile and more likely to cross the midline. For the pattern of tumor spread, Wilms tumor have direct expansion with displacement of adjacent structures, but for neuroblastoma, they encase blood vessels and they cause aortic elevation. For the age, neuroblastoma occurs at a younger age, and neuroblastoma have painful abdominal mass, whereas nephroblastoma or the Wilms tumor have painless abdominal mass. Calcification is very common for neuroblastoma, which is uncommon in Wilms tumor. The tumor composition of neuroblastoma is that they are solid mass lesion and rarely cystic, but Wilms tumor are often cystic. The tumor margin is poorly marginated for the neuroblastoma and well circumscribed for the Wilms tumor. For the vessel involvement, the neuroblastoma have access to vascular structures but does not invade them. But Wilms tumor or the nephroblastoma displaces the adjacent structure and invades the vasculature. For the metastatic sites, neuroblastoma, the most common metastatic site is the bone marrow, followed by the liver and the lung. But for nephroblastoma, lung is the most common metastatic site, followed by the liver and the local lymph nodes. The kidney is the site of approximately 7% of childhood malignancies, and the vast majority of pediatric renal tumors are the Wilms tumor in children less than 15 years old. Wilms tumor is higher for Black population and lower in Asians like us. It occurs at an early age among boys, and 5 to 7% have bilateral disease. 10% have congenital anomalies. Wilms tumor are typically solitary lesions with no predilection for the left or right kidney or sites within the kidney. 10% arise multifocally within a single kidney, and 7% involve both kidneys either at presentation or subsequently. Extrarenal Wilms tumors are rare, and others are found in the pelvis, inguinal region, and the thorax. So what are the symptoms of Wilms tumor? It presents as asymptomatic abdominal mass that is incidentally noted while bathing or dressing the child. The pain is seen in approximately 40% of children, and fever is less commonly observed. Gross or microscopic hematuria may occur on intermittent basis, but finding Wilms tumor as a cause of gross hematuria in childhood is rare. Hypertension occurs in a quarter of patients caused by increased renin secretion, and it may be severe, resulting in encephalopathy and retinal hemorrhage. Hypercalcemia is uncommon but more on rhabdoid tumors. The abdominal mass is typically smooth and eccentrically located in the abdomen towards the flank. The lung metastasis in Wilms tumor may cause pulmonary insufficiency and congestive heart failure. Obstruction of the inferior vena cava will lead to the presence of prominent abdominal wall vessels, varicocele, and then consequent spermatic vein thrombosis. Rarely, pulmonary embolism can also happen. 7% of patients with Wilms tumor have known syndromic association with Dennis-Drash syndrome, Wagner, and Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome manifests with macroglossia, macrosomia, organomegaly, or developmental abnormalities. Therefore, if you have patients with Wilms tumor, it is also good to look for these abnormalities in the patient. Wagner syndrome is Wilms tumor, aniridia, genitourinary tract anomalies, and mental retardation syndrome. Dennis-Drush syndrome is composed of the following. Other associated defects of Wilms tumor are cryptorchidism and hypospadias. So check also for the genitalia of patients with Wilms tumor. For the diagnostics, we can request CBC, urinalysis to check for hematuria, blood chemistries, chest CT scan, and bone scan. Ultrasound, including Doppler of renal vein and inferior vena cava, abdominal CT scan, or MRI will assess the presence and function of the opposite kidney. We'll check for the evidence of bilateral lesions. We'll see the renal vein or inferior vena cava tumor, lymph node involvement, and liver metastasis. For the patterns of spread of Wilms tumor, it can be locally or hematogenously. Locally through the renal capsule and directly into the renal sinus or the ureter. Contiguous spread through the renal vein into the inferior vena cava in 4 to 10%, rare direct extension into the right atrium, and regional lymph node and spread. Hematogenous metastases are uncommon, and when present, it more frequently involves the lung, the liver, and rarely the bone marrow or the brain. For the management of Wilms tumors, like any other tumors, first is surgery for the diagnosis, chemotherapy, and radiotherapy. For the surgery, surgical removal of the tumor is a major component of the multidisciplinary treatment. Surgical procedure of choice is unilateral radical ureteronephrectomy with lymph node sampling. For the prognosis, usually we check for the loss of heterozygosity at chromosome 1p and 16q, and this is associated with inferior relapse-free survival and overall survival. So the stage with loss of heterozygosity have inferior relapse-free survival and overall survival. So early diagnosis can save the lives of many children. That's why I hope that after this lecture, we will be able to diagnose cancer in children earlier, so that management can be instituted earlier for a better prognosis. Let's all beat childhood cancer. Thank you.